Hello everybody, I'm back with another video, a very important video on a rather important topic which has been some sort of a place, a breeding ground for so many confusion and controversy. And the topic is called how to manage or management of diabetic foot. Not that you don't know how to manage a diabetic foot. The problem most of you guys have with exam questions is the order of the things you have to consider. Like, for example, let me tell you something. Mr. John Doe has presented to you with an ulcer which is similar to diabetic foot or diabetic ulcer. And the scenario either explains the wound in words or they just give you a picture, a photograph of the wound, and they mentioned that we already, X, Y, Z has already been done for the patient. What is going to be the most appropriate next step in management? And this is where the confusion arises, and we're here to solve this confusion once and for all, hopefully. So, like I told you, this is the diabetic foot, and I'm going to present the topic to you today. It's my honor. And before I go any further, please understand that none of these videos or contents in AMEDEX are intended to be used as practice guidelines. We're just putting them out for you for your exam preparation purposes only. So when it comes to medical practice, you always need to consult with your supervisor, with your clinic manager, your more expert colleagues, and so on and so forth. Please don't consider these contents and material as practice guidelines. They're just solely for your exam preparation purposes. Okay, let's bring the lecturer onto the screen and go on. Hello again. Okay, diabetic foot. What I'm going to talk about today is the order through which we manage diabetic foot. We call it stepwise management of diabetic foot. Remember, when it comes to management of diabetic foot, first step is always after just, the routine stuff, history, physical examination, making sure that the patient's stable. What we're going to do, A, B, C, D, E. If the patient's not vitally or clinically stable. When it comes to just exam purposes, the first thing you need to consider is always debridement. I'm going to talk about that in more detail later on. So debridement, when we are dealing with a diabetic foot ulcer, we always do and consider debridement first. Okay, second, after we did the debridement, what we're going to do is just taking swabs from the wound for microscopy, culture, and sensitivity. This is very important because in most scenarios, we're going to prescribe or give the patient antibiotics. So as we know, antibiotics might affect the test. So this is why we take swabs before we start patient on antibiotics if they are indicated. So we have 3 steps so far. 1, debridement, 2, wound swab for MCS, and 3, antibiotics if indicated. 4th is X-ray of both feet, not just the affected one, both feet for comparison. And we're going to talk about that later on again. 5th step is MRI only if indicated, not always. And at the end of the day, other tests we might consider for the patient. So it goes like this. The patient has presented with diabetic foot, and the debrident's been already done. What's going to be the next step in management? Wound swab. Okay, the patient, Miss Smith, comes with a diabetic ulcer on her foot, and debridement and wound swab has already been taken, have already been done. What would you do next? Antibiotics. Okay, like Mr. John Smith presents to the emergency department. Diabetic foot, same old stuff. Debridement, wound swabs, and antibiotics has been started or done and started. What's going to be next? X-ray of both feet. Okay, so now you have an order to follow. We have these 6 steps in order of importance for management of diabetic foot. Let's talk about these steps one by one in more detail. Debridements, like I told you, this is the very first step in management of diabetic foot. And the reason is it has some benefits. It allows you to just evaluate, assess the wounds thoroughly and completely. Allows comprehensive evaluation of the wound bed, and actual wound size, which is a very important factor when it comes to management of the diabetic foot. Wound bed, I mean all of them, wound bed and the wound size. And it also may convert a chronic wound to an acute one with accelerated healing. You know, sometimes it happens in medicine. We want to just turn a chronic condition into an acute condition where the body can take care of that better. And it also reduces local pressure on the wounds, which is a great thing for diabetic foot. We have two types of debridements. Non-surgical, where you just remove, you achieve all these goals by filing the scale and calluses, or just putting some ointment or cream for chemical debridement and things like that. We're not going to just deep down in detail because it's not relevant to your exam questions, but just to let you know, we have two types of debridements. The first one is non-surgical and surgical. Surgical, you take a blade and you play surgeon, and it always comes first. A very important thing to consider is that if we have some sort of vascular compromise, like the patient's in front of you, you're examining him, you see a diabetic foot ulcer, and you also realize that this patient, the ulcer is on the right foot, and in the right leg, you suspect the presence of vascular compromise. You do the debridement, you're going to be in deep trouble, so please do a full assessment of the vascular status if you suspect vascular compromise before you go ahead and do the surgical debridements. If I were you, I would refer the patients for further assessment by specialists in real life after I did some initial step for the patient. Okay. Second, like I told you before, is wound swab for microscopy culture sensitivity. We might do the swab, we might do an aspiration, regardless of what technique we use, the aim, the target, the goal of, aspiration or swab or whatever, sampling the wounds is sending in for microscopy, culture, and sensitivity prior to commencement of antibiotics. They say that if the infection is evident, suspected, do the swab or sampling. But in reality, and what they also recommend is even the wound doesn't look infectious, doesn't have an odor, seems clean, has granulation tissue. Just to be on the safe side, maybe you want to do the swab. So for practical purposes, we always do wound swab and sampling after debridements. We have two notes here. We're going to talk about that. I haven't seen any exam questions, focusing on these two notes, but just they're here if you're interested. The first one is very important though. If an ulcer can be probed down to bone, osteomyelitis is likely, and MRI is indicated. We will be talking about indications for MRI in diabetic foot in a short while, but for now, please remember, you are probing the wounds as a step in management of the diabetic foot. Here in the part wound swab for microscopy, culture, and sensitivity. And you realize that the wound is deep. You go down, and all of a sudden you feel the bone. Oh, my needle is touching the bone. So you suspect osteomyelitis. Maybe the patient has osteomyelitis, and you have to put MRI as an option, as a thing you need to do for this patient. And note 2 says that if we isolate a pathogen, like we do the swab, and we have a growth, a bacterial growth, and we realize that we have just isolated species, bacteria, without having evident signs of infection. In that case, just to be on the safe side, we use bactericidal dressing, like things that contain nanocrystalline silver, like topical antibiotics, in order to clear the wounds of bacteria. So again, I'm going to repeat that again and again. Debridement, wound swab for microscopy culture and sensitivity. Next part is antibiotics if indicated. I'm going to go through details with this topic because this is very important when we've had a lot of questions revolving around this just choice of antibiotics for diabetic foot. First of all, antibiotics are indicated if there is minimal inflammation but there is odorous wound secretions. Just you come across a diabetic foot ulcer, everything's clean, no sign of infection, no inflammation, but you sniff it and it smells like hell. It's malodorous, so you're going to consider antibiotics for that patient even without having any signs or symptoms of infection. Just the odor is enough to just give us the go-ahead with antibiotics. And the second thing, in the presence of moderate to severe infection, choices of antibiotics depend on the wound characteristic and associated symptoms. And this is a very important thing I'm going to talk about right now. Decision as to commencement and type of antibiotics in diabetic foot. This table is going to be your friends. Okay, so I think it's from RACGP or another Australian guideline, I can't remember right now. They have actually divided diabetic wounds into 4 categories. And they have explained the characteristics of each category and antibiotic therapy of choice for each category. Okay, first category is uninfected wounds. And let's go through the characteristics together. Wound does not have purulence or any manifestations of inflammation, like I told you before. Antibiotic therapy is not required unless the ulcer is odorous. Treat as mild infection. Without odor, only daily wet dressing. Okay, this could be a question. Like Jane has presented to your clinic with a diabetic foot ulcer, and they give you a picture. We have no erythema, we have no pain, tenderness, oozing, sign of inflammation, and there is no odor. The only thing we do is we do daily wet dressing. This is going to be the correct option, the correct answer. But if the wound is odorous, you smell something, you're going to treat that as mild infection, maybe by putting some topical antibiotic on top of the wounds. Okay, for the second category, mild infection, how do we define mild infection? We have an ulcer, we have a wound, and we have 2 or more of the manifestations of inflammation, which are purulence. We have secretions, purulence, erythema, redness, pain, tenderness, warmth. You touch the wound, it feels warm to touch. Or induration, it's hard. Okay, so we're going to repeat that together again, just to make sure that you understood. Manifestation of inflammation are purulence or secretions, erythema or redness, pain, tenderness, warmth, or induration. 2 of these equals mild infection, provided that we don't have any cellulitis or erythema greater than 2 centimeter, and this is not or, this is and. So the wound should be less than the cellulitis, the superficial infection around the ulcer should be less than 2 centimeter, and no extension beyond superficial subcutaneous tissue, and no systemic illness. I'm going to talk about that later on in this table. So for mild infections, what we recommend is oral amoxicillin plus clavulanate or cephalexin plus metronidazole. If the patient is penicillin allergic, I'm going to give them ciprofloxacin plus clindamycin. Just memorize them, learn them by heart. Oral amoxicillin, just coamoxiclav or amoxicillin clavulanate, or we can just substitute that with cephalexin plus metronidazole to cover anaerobes. If the patient is penicillin allergic, we're going to give him or give her ciprofloxacin plus clindamycin. So this is mild infection. Let's go through it again. Uninfected, we have no sign of inflammation or purulence, and here comes the branch, the fork. If we have odor, we just treat as mild infection. No odor, only daily wet dressing. Mild infection, we have 2 or more of inflammatory signs, but no cellulitis greater than 2 centimeters around the ulcer, no systemic involvements like fever and chills, and also no spread beyond the superficial or subcutaneous tissue. Okay, we call this mild infection. We give the patient either amoxicillin clavulanate or cephalexin plus metronidazole, and if the patient is allergic to penicillin, we give him ciprofloxacin plus clindamycin. If you want just further information, you might want to check therapeutic guidelines. It's a very good thing to have, but it's a little bit expensive. You have to pay like $500 per year. Moderate infection. Moderate infection is mild infection, meaning that it has 2 or more inflammatory signs plus a cellulitis that is extending, beyond 2 centimeters. Or, either of these items plus mild infection is going to be moderate infection. Again, we have mild infection, meaning that we are dealing with 2 inflammatory signs plus cellulitis extending more than 2 centimeters, or lymphangitic streaking or extension beyond superficial fascia, tip tissue, abscess, gangrene, or extension to muscle, tendon, joint, or bone. No systemic involvement. On the top of that, if we put systemic involvement, we're going to have severe infection. What do we do for moderate infection? Dicloxacillin or flucloxacillin. This is the first choice, and it says metronidazole must be added if the wound's discharges are odorous. It shows that we have some anaerobe activity. For that, we're going to add metronidazole on the top of dicloxacillin, flucloxacillin, which are synthetic penicillins. Severe infection. Severe infection is moderate infection and systemic toxicity or metabolic instability like fever, chills, tachycardia, hypotension, confusion, vomiting, leukocytosis, severe hypoglycemia, or azotemia. So, just to wrap it up, uninfected, either wet dressing or topical treatment. Mild infection, we have 2 or more manifestation of inflammation, but we have no cellulitis greater than 2 centimeters, we have no extension beyond subcutaneous tissue, and we have no systemic involvements. Okay? For moderate infection, we have more than two inflammatory signs, plus cellulitis, which has extended beyond 2 centimeters, or lymphangitic streaking, or extension beyond superficial fascia, deep tissue, abscess, gangrene, or extension to muscle, tendon, joint, or bone, and no systemic involvements. Plus systemic involvement, we're dealing with severe infection. For severe infection, what we do, we prescribe piperacillin plus tazobactam or ticarcillin plus clavulanate if the patient is penicillin allergic. Now, another option is ciprofloxacin plus either clindamycin or lincomycin. Okay? Just learn this table by heart. Know the definitions of each category of the wounds, know the characteristics, and know what choice of antibiotics do we have for every category. Right? Debridement swab, sampling, and antibiotics covered. Down. Let's go and talk about X-ray. If we have clinical signs of inflammation, always obtain or get lateral, anteroposterior, and oblique X-ray views of both feet. This is for comparison. Patients with diabetic foot have compromised bone problem, bone or joints in general. And this is why we want to make sure that this patient presenting with diabetic foot doesn't have any osteomyelitis, diabetic arthropathy, or gas formation. This is very important. And while we're here, let's talk about how useful X-rays could be for diagnosis of osteomyelitis. It takes 1 to 3 weeks before we even are able to see the slightest signs of osteomyelitis on an X-ray, which is periosteal elevation. So if you consider X-rays for exclusion of osteomyelitis, we want to repeat that every 1 to 4 weeks in order to see if there are any changes on X-ray that we could notice. MRI the affected area may be useful for differentiating infectious from non-infectious inflammatory conditions. However, if MRI facilities are not available, a surgeon should be able to decide regarding exploration and debridement of an ulcer based on clinical examination. Forget about that. Whenever it comes to may, forget about that. It's not going to be a just definite answer for that question. MRI. When the answer is going to be MRI, where MRI is indicated, in other words, MRI is indicated if osteomyelitis is suspected based on the following. We give the patient antibiotics and we don't receive the expected response. We suspect osteomyelitis. Maybe we're dealing with osteomyelitis. We refer the patient for MRI. Like I told you before, we probe the wounds and we get deep down enough to touch the bone. We suspect osteomyelitis and we do MRI. When you're exploring the wound or in follow-up visits, you see the bone at the base of the wound. You order MRI. And you're doing this X-ray as a part of your job for following up this patient. And you realize that you're suspecting signs of bone infection on X-ray. The first sign, like I told you before, is periosteal elevation. You see this layer of periost just coming off the bone and forming a curve like this. MRI and other tests. It's other tests. Full blood count, ESR, electrolytes, blood glucose, and hemoglobin A1C, renal and liver function tests should be all considered and offered to all patients presenting with diabetic foot. Weekly measurements of CRP during treatment of foot infection may help monitor the response to treatments. So it's not going to be a correct answer for your exam purposes, probably. Surgical biopsy of affected area may be useful for collection of subsequent specimens for microbiological blah 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 blah. Forget about that. So let's go over the steps you need to take for treatments, management of diabetic foot. Debridement, sampling by swabbing or aspiration of the wound, antibiotics if indicated, X-ray of both feet, MRI if indicated, and other tests. Okay guys, that was it for today, and I hope to see you very soon with another very exciting and interesting video on challenging topics for your AMC MCQ exam preparation. Ciao.